Good morning and welcome to Day 2 of this public meeting of the Physician-Focused Payment Model Technical Advisory Committee known as PTAC. My name is Dr. Chini Puluru and I'm one of the co-chairs of PTAC along with Dr. Lee Mills. Today we begin our day with opening remarks from Mr. Abe Sutton, the Director of Center for Medicare and Medicaid Innovation and Deputy Administrator for the Centers for Medicare and Medicaid Services. We are very honored to have him with us here today. Mr. Sutton previously served as a principal at Rubicon Founders, where he co-founded two health service companies, Honest Health, which focuses on enabling primary care physicians, and Evergreen Nephrology, which focuses on enabling nephrologists in kidney care. From 2017 to 2019, he also served at the National Economic Council, Domestic Policy Council, and Department of Health and Human Services. In these roles, he coordinated health policy across the federal government with a focus on value-based care, increasing choice and competition in healthcare markets, and updating the federal government's approach to kidney care. Thank you, Abe, for being here.
Thank you for those kind introductory remarks. Good morning to you, the members of the Physician Focus Model Technical Advisory Committee, and the public in the audience and listening in today. I'm so appreciative of the invitation to give some brief remarks today as the new director of the Innovation Center. To begin, I should say that I've been aware of the work of this committee in my prior role as an advisor to Secretary Azar focused on value-based transformation in the first Trump administration, and I'm also aware of the transition the committee has made to focusing on theme-based discussions in each session as a way to get critical input on value-based care to the Innovation Center. In particular, the last meeting's focus on discussing strategic priorities for the Innovation Center is a critical input for us to have at this time, and I'm grateful for the focus of this committee in those recent discussions. We welcome this public discussion from leading physician voices in value-based payment and appreciate your focus and attention. I know you're taking time away from other activities that you could be doing and are appreciative of you doing so. I'm overjoyed to be the new director of the CMS Innovation Center. I believe deeply in our work as a center and the mandate we have from Congress to design models that will improve the quality of care and reduce the cost of care. This commitment is aligned to the vision of Secretary Kennedy and our CMS Administrator nominee, Dr. Oz. I see it as a commitment to the taxpayers supporting our system and the beneficiaries that we care for, to make sure we're efficiently stewarding the resources entrusted to us and delivering the delivery system reform that will make us efficient and improve the quality of care. We have a great model portfolio at the Innovation Center, and much of our work will be building on the past successes of the center. But I also want to make clear that my focus as director and the focus of the great team at the center will be on designing models to be certifiable. That is our metric for success. Over the coming months, you will hear from me and my team about how this vision will come into focus in the future. We're currently conducting a review of our portfolio and we'll have more to share from that in the future. As we go forward, I expect our vision will emphasize prevention and management of chronic disease and using data to empower people to meet their health goals. We also, aligned with the focus of today's discussion, want to understand how to promote choice and competition in healthcare markets, as we know if there's competition in the marketplace, we'll be able to provide better care and patients will win. I look forward to sharing more at a future meeting, but I will emphasize that all our work is aligned to the Secretary's vision for how we can make America healthy again. To close, I want to thank the members of the PTAC for their commitment to creating this forum for robust discussion, where we hear from those in the field directly convening their ideas and concerns on how we can deliver high-value care for Medicare beneficiaries. This independent expert committee is a critical resource as we develop the way forward to achieve Secretary Kennedy's vision and accomplish our goals as a center. Thank you.
Thank you for sharing those remarks, Abe. We appreciate your continued support and engagement, and we look forward to continuing to collaborate with the Innovation Center. Yesterday, we had several expert panelists and presenters share their perspectives on reducing barriers to participation in population-based total cost of care models and supporting primary and specialty care transformation. Thank you. Today, we have a great lineup of experts for a one-panel discussion and one listening session. We have worked hard to include a variety of perspectives throughout this two-day public meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed model. Later this afternoon, we will have a public comment period and welcome participants either in person or via telephone to share a comment. As a reminder, public comments will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to, please email ptacregistration@norc.org. Prior to the 1:20 p.m. public comment period today, that's Eastern Standard Time. Again, that's ptacregistration@norc.org. Then the committee will discuss our comments and recommendations for the report to the Secretary of HHS. Because we might have some new folks online who weren't able to join yesterday, I'd like the committee members to please introduce themselves. Share your name and your organization if you would like. You can tell us about your experience with our topic. I will cue each of you. I'll start. Hi, I'm Chini Puluru. I'm a family physician by trade with 20 years of experience implementing value-based care models, both at a multi-specialty provider group as well as Walmart Health and Wellness. Most recently, I am fractional chief medical officer of Stellar Health, a technology-based value-based care enablement company, as well as consult across the landscape with large and small payer and provider groups, as well as hospitals in the last mile of transformation in value-based care. With that, I will lean it over to Lee.
Good morning. I'm Lee Mills. I'm a family physician as well. I am Chief Medical Officer of Aetna Better Health of Oklahoma, one of the state Medicaid plans. And before that, I was Chief Medical Officer of a provider-owned private health plan operating in the Medicare Advantage and commercial space. Before that, I was in medical group and integrated health system leadership in several states, and I've had the privilege and pleasure to help implement, operate, and lead 6 or 7 different CMMI pilots over my 25 years in operations. Thank you.
Next, let's go around the table. Hanesh?
Hi, good morning, everyone. My name is Hanesh Bansali. I'm a primary care doctor and general medicine doctor by training. I serve as the Chief Medical Officer for Medical Home Network. We work with community health centers across the country to help transform them and move them into value-based care. Prior to that, I was at Dooley or DuPage Medical Group for 2 years as their Senior Vice President for Medicare Advantage. Prior to that, I was at Oak Street Health as their VP and National Medical Director for Care Navigation. Prior to that, I was in academics, caring for undocumented and Medicaid patients. Thank you.
Jay.
Good morning, everyone. My name is Jay Feldstein. I'm currently the President and CEO of Philadelphia College of Osteopathic Medicine. I'm an emergency medicine physician by training, and prior to this role, I spent 15 years in the health insurance industry, both as a chief medical officer and running plans themselves in both governmental and commercial plans.
Morning all, Krishna Ramachandran, Senior Vice President, Health Transformation, Blue Shield of California. I've spent the past 15 years of my life furthering value-based care from technology, provider, and payer perspectives. Spent time in a large multi-specialty group prior to the payer side, and then worked for about 8 years at Epic before that. Thanks. Larry?
I'm Larry Kaczynski. I'm a retired gastroenterologist. I've spent the last 10 years of my life in value-based care, which actually started as a proposal presented to this committee, Project Sonar, which became the foundation for a company, Sonar MD, which I founded. I have been involved in building value-based care in the specialty space and have been on this committee for 3 years.
Good morning. I'm Walter Lynn, founder of Generation Clinical Partners. GCP is a small independent medical practice based in St. Louis and Southern Illinois, focused on caring for the frail elderly in senior living organizations. We've been involved in a number of different value-based care programs, including institutional special needs plans, MSSP ACOs, bundled payments, PACE programs, and most recently I took the position as the clinical strategy officer of LTC ACO.
Good morning. I'm Lauren Harden. I'm a nurse by training and Chief Integration Officer for HC2 Strategies, where we focus on building connected communities of care for high cost, high needs, and complex populations in partnership with states, communities, multi-state health systems, and payers. I've spent the better part of the last 20 years focused on high needs populations, originally designing models with hospice, palliative care, and one of the first children's hospice and palliative care programs, and then moved into the area of complex care, was part of the team at Camden that developed the National Center for Complex Health and Social Needs, and spent 8 years traveling around the country in more than 30 states, starting up models to meet those population needs.
Good morning, Jim Walton. I'm a part-time healthcare consultant now, retired internal medicine physician, and started my practice in Ellis County, Texas, and then transitioned to Dallas, Texas, where I practiced internal medicine and led a large healthcare systems community medicine strategy, as well as serving as their chief health equity officer, and then transitioned to lead a large IPA in Dallas and North Texas in their efforts to build out accountable care strategies for primary care physicians in Medicaid, Medicare, MSSP contracts, and commercial Medicare Advantage contracts. And I've served on PTAC for the last 2.5 years.
Let's go now to our PTAC members joining us on Zoom, starting with Lindsay.
Yeah, good morning, everyone. I'm Lindsay Botsford. I'm a family physician in Houston, Texas, where I continue to see patients as a PCP and serve as the regional medical director for the Midwest and Texas with One Medical. In that capacity, I serve as the chair of the governing body of our ACO REACH entity, which we've been a participant since the inception of the program. Again, I continue to see patients as a PCP in Houston, and prior to that, worked both in academics and large health systems. Thanks.
Next, we have Josh. Please go ahead.
Great. Hi, everybody. Josh O'Lau, an internal medicine physician professor at the University of Texas, Southwestern Medical Center. Spent the last decade on a combination of activities that are relevant to this committee's work, studying kind of the technical aspects and evaluation of payment and care delivery innovations, as well as leading the strategic design, evaluation, and consideration, organizational strategy for payment and delivery innovations for integrated delivery systems, as well as working with population health and other care delivery teams to actually implement these things in clinics and hospitals.
Thank you all. For today's agenda, we will explore a range of topics on reducing barriers to participation in population-based total cost of care models and supporting primary and specialty care transformation that include a panel discussion on enhancing the ability of population-based total cost of care models to be competitive, and our third listening session, which will look at how to maximize participation of beneficiaries in accountable care and improve the sustainability of effective population-based total cost of care models. The background materials for this public meeting, including an environmental scan, are posted online on the ASPE PTAC website meetings page. The discussions, materials, and public comments from the March PTAC public meeting will all inform a report to the Secretary of HHS on reducing barriers to participation in population-based total cost of care models and supporting primary and specialty care transformation. Lastly, I'll note, as always, the committee is ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters, allowing flexibility depending on the level of detail of their payment methodology. You can find information about submitting a proposal on the ASPE PTAC website. And now I'm excited to welcome our roundtable panel discussion. At this time, I ask our panelists to go ahead and turn on video if you haven't done so already. In this session, we've invited 4 esteemed experts to discuss their perspectives on enhancing the ability of population-based total cost of care models to be competitive. After each panelist offers a brief overview of their work, I will facilitate the discussion on asking each panelist questions on the topic. The full biographies of our panelists can be found online, along with other materials for today's meeting. I will briefly introduce each of our guests and give them a few minutes each to introduce themselves. After all 4 introductions, we will have plenty of time to ask questions and engage in what we hope will be a robust discussion. First, we have Dr. J. Michael McWilliams, the Warren Alpert Foundation Professor of Healthcare Policy and Professor of Medicine in the Department of Healthcare Policy at Harvard Medical School. Michael, welcome.
Thank you very much. It's really a pleasure to be with you all this morning. Thanks for the invitation. So I should say, first of all, by way of sort of a disclaimer, that I serve as a senior advisor to the Innovation Center, but I am here this morning as a professor of healthcare policy, as a researcher. So my comments should not be construed as representing the views of the Innovation Center or CMS. If you could just go to the next slide. Great. So I joined a session in September at the last PTAC meeting, and the theme of that session was participation. And so the first bullet of my first slide was the same here, which is that the goal is not participation. And so I inserted the word competitiveness, which is the theme today, because the goal is not competitiveness either per se, it's success. And so we can talk about what it means to be, what success means. I think most people would say some version of savings without any harm or more value at a lower cost. And competitiveness may be very important to success, but I think it's important that we define what we mean by competitiveness. For example, I don't think we want competitiveness for the sake of competitiveness. If it means letting ACOs sort of game the system and increase spending by 20% just so they're at the same level with MA insurers. So I have some thoughts here on what we mean by competitiveness of total cost of care models with fee-for-service in MA. And when we talk about it with respect to fee-for-service, I think what we really mean, what we're really talking about, or at least what we should be talking about, is ACO contract design, sort of the model design. Providers are the ones who decide whether to be in an ACO. So for total cost of care models to succeed, then we have to give providers an incentive to be efficient. We have to let them keep some of the savings as they limit intensity and volume. The main problem here has been various ratchet effects whereby Medicare claws back the savings as they are produced, such that there is very little incentive for providers to ever save in the first place, or so that only some providers can ever sort of win the game. Basically, if success begets failure, we shouldn't ever expect success. And there is this sort of implicit pervading notion in the benchmarking that benchmarks should be equal to claims expenditures. But of course, paying at the level of claims expenditures is called fee-for-service. So this would be my main point for this morning. I can't underscore it enough, the importance of fixing the design problems in the total cost of care contracts, because in reality, the ACO models really haven't moved that far from fee-for-service. So you could say ACOs are quite competitive with fee-for-service, but obviously not in the way that we want. In terms of competitiveness of total cost of care models with MA, Medicare Advantage, this is really more about payment policy favoring Medicare Advantage over traditional Medicare, because even if we can fix the core incentive problems in ACO contracts, ACOs can never compete with MA because MA is so heavily subsidized. Those subsidies translate into better coverage for beneficiaries, and being in MA is really a beneficiary decision. It's an enrollment decision. So we should absolutely consider various improvements and additional features to ACO models, but there's really no amount of ACO contract redesign that can make ACOs compete with MA when out-of-pocket costs are thousands of dollars lower in MA. So before we even think about ACOs, I think there are some broader structural questions about whether we want a more even playing field between the programs and Medicare. How much do we need to rely on traditional Medicare to discipline the MA market? And by that, I mean pressure plans into sharing more of their profits with enrollees as additional benefits, trying to curb more overly restrictive practices. And that in turn depends on a bunch of questions like, how much can we depend on competition within MA to get what we want out of the program? If insurer competition is limited or unproductive, and there's certainly evidence of it being far from perfect, how well can we regulate the program directly without relying on traditional Medicare to exert pressure in sort of more indirect ways? And if we do want to level the playing field, at what level of payment? One way to level the field is to cut Medicare Advantage by the 15 or 20% or whatever it takes to even the field. But then enrollees may lose benefits, and we may want seniors to keep some of the coverage gains achieved by Medicare Advantage. So if we're talking about competitiveness in Medicare, this is sort of the stuff that we need to talk about. Can we fix the risk adjustment system to get the rents out and put an end to competition to code, but without cutting benefits too much? Can we help beneficiaries shop for high-value plans to drive more competition? Can we regulate prior auth without undermining the ability of MA to save money? How much of that is better accomplished by having a traditional Medicare program that doesn't cost $8,000 or $9,000 out of pocket a year? And then finally, I'll just say 2 points about the role of ACOs or total cost of care contracts in the interaction between the two programs. One is if incentives in ACO models can be strengthened, that can lower the cost of leveraging traditional Medicare to discipline the MA market. Basically, if we need traditional Medicare around and generous enough to do that, we don't want it to be horribly inefficient, thus ACOs. And second, if we can develop ways for ACOs to share savings more directly with patients like MA plans do, that could foster demand for efficiency in traditional Medicare too, help strengthen ACO incentives, but also help pressure MA plans to sort of elevate their game. Then if you could just go to the next slide, I think I'm probably over my allotted 3 minutes by now. So I'll just try to mention these points very quickly. Another vein in which folks talk about competitiveness is sometimes we just mean better. We want something to be better. We want total cost of care models to work better. And that, of course, begs the question, why? What do we get out of making these models better? Why do we think that they have some added value? And I think, obviously, they can help save the system money, but I think the real conceptual advantage of population-based payment is it can help navigate a really core trade-off in payment policy between cost containment and access or quality. Basically, these models can help us get more value out of the spending in various ways, and I've listed some of the ways that they can do that. If you think about fee reductions as an alternative cost control measure, we worry about access problems as fees are reduced for too much for too long. But if providers can gain from efficiency, then that can help preserve access as spending is reduced. They can provide an alternative way to finance services that are really hard to price and therefore prone to overuse or underuse in fee-for-service when mispriced. As care delivery gets more complex, it just gets harder and harder to separate everything out into little parts and price everything correctly. And so total cost of care models allow a way to sort of not have to pay separately for everything if things reduce costs. So if there's an incentive to reduce costs, those things should diffuse anyway, and to provide a stream of no strings attached revenue that can be used more flexibly but with a limit. Another way is they sort of minimize incentives that get in the way of providers doing what they think is in patients' best interests. So for example, physicians don't have to do 30 office visits a day just to keep the lights on. And also if providers are bearing the risk, to enlist providers who are more informed and who deliver the care in maybe more clinically nuanced utilization management. And then the final point I think we will get to later in terms of multi-payer alignment. So I will stop there and greatly look forward to the discussion. Thank you.
Thank you, Michael. Next, we have Dr. Stephen Shortell, the Blue Cross of California Distinguished Professor of Health Policy and Management Emeritus, Dean Emeritus and Professor of the Graduate School of Public Health and Haas School of Business at the University of California, Berkeley. Steve, please go ahead.
Thank you. I'm happy to be here and engage with the discussion and all the great work that people are doing. And let me just say something a little bit about my background. I just listed out there a few items relevant, I think, to our discussion today. I'm now a researcher. I have been a researcher and now an emeritus at Berkeley, continue to do work on health policy research, ACOs, and so on. The Better Healthcare Policy Group, there's 8 of us from different facets of the healthcare field that have been working on some of the issues that are on the agenda today. So I just want to highlight that in that we have 3 ongoing work groups that some people may want to know about or join from time to time. One working group is working on really the relationship between the 3 major stakeholders around the issues we're discussing today: health plans, providers, and then in the commercial market, employers. How do we get employers in this country to purchase more wisely in terms of better care? And we have a work group working on that. We have another one on transparency in terms of patient safety and quality, involving a lot of the safety experts in the country, Leapfrog, Epic, and so on. I've also been on the Office of Healthcare Affordability Advisory Committee here in California around spending targets. Other states are doing that. We may want to talk about that today as well. If we go to the next slide, what I want to do is I've been asked to talk about really vertical integration, simply put, right, the relationship between medical groups, physician practice, hospitals, and health systems, where there's an ownership or very strong affiliation relationship. What's the evidence that this promotes better care or just increases prices, et cetera? What are the implications for value-based payment? And I'll try to hit some of the highlights of that and then welcome the discussion we're going to have. First of all, let's look at the evidence that vertical integration is associated with increasing negotiation leverage on the part of hospitals and health systems when they integrate with physician organizations, and it's associated with increased prices. There's little doubt about that. There's pretty much overwhelming evidence that indeed that does occur. One thing that's been new on the scene is private equity. Some of these arrangements are private equity owned, and there's some emerging evidence that their prices are 1.5 to 3 times that of other ownership models. So this is an issue. Cutting to the quick, thinking, what might be done about that from an antitrust perspective. Some people have talked about the idea of contingent approval of these relationships beyond a certain monetary amount, in which you contingently approve the vertical integration purchase or relationship contingent on, for example, after a year or 2, evidence on reducing, for example, preventable hospital admissions, ambulatory care sensitive admissions, for example. Diabetes patients shouldn't end up in the hospital and so on. Or you make it contingent on reducing readmissions or on hospital infections, for example. And so you can begin to think of tying these relationships to performance indicators before giving full approval. That's just one example. We can come back to that. If you're participating in an ACO around these vertically integrated relationships, then the above issues that I've talked about may be attenuated to some extent, right? Due to the incentives to share in savings that Michael has indicated and some of the evidence on that regarding total cost of care. The national evidence, and Michael and his colleagues at Harvard have produced some of this as well as others, that probably ACOs reduce cost savings around 1%, 1.5% on average, while maintaining or maybe even improving quality of care metrics. Here in California, for years, we've had the delegated care model, many of which are ACOs, in which there's data from the Integrated Healthcare Association that our medical groups that are under full risk have significantly lower total cost of care and higher quality of care on various clinical metrics than those that are partial risk. Partial risk models here are for outpatient only, don't include hospital, and they in turn perform better than the fee for service. So California has some pretty consistent data over about 10 years now on some of these kinds of models. The research suggests that hospital-affiliated ACOs tend to have higher overall spending than the independent physician-affiliated ACO groups due to higher inpatient use and specialty services. There's also the issue of hospitals needing to spread their overhead. There's also the issue that's being partially addressed, the facility fees being higher if it's hospital outpatient than other. Independent practices, they tend to reduce the inpatient care that is used, and also specialty services. Hospitals, you can argue, might have a natural incentive to fill the beds when in doubt. And so this is pretty consistent that the independent physician affiliated ACO groups tend to perform better on some of those kinds of metrics. No consistent differences in regard to quality of care. Some evidence that the independent physician groups in terms of patient communication or patient satisfaction with communication a bit higher on the independent side, but no consistent differences in regard to other metrics. Let me wind up with the challenge here, and that is, in my mind, and we begin to discuss on this with some of Michael's comments, how do we design these payment models to take advantage of the resources and infrastructure that hospitals and health systems can provide to medical groups that also reduce the incentive, though, to increase spending. So moving towards the all-payer and the multi-payer is really key here. Risk-adjusted prospective payment, moving towards global budgets, Maryland, and so on. What are some of the things to push this along with all the challenges that are involved? And I think some of them, and we'll get to them, the need to standardize these measures that are an administrative burden when they aren't standardized with different payers and so on. Progress is being made in some states on that. Attribution issues, the setting of the targets, of the benchmarking that's been alluded to, and not only in terms of the ratcheting down, but also how do you get the smaller practices under the umbrella here in terms of making some rewards for improvement. So maybe you don't hit the target, but you get something for improving from year to year, for example. And then upfront investment in capabilities for smaller and rural practices. CMS is doing, I think, a reasonably good job of that. Some of the states also, but more could be done in that area as well. And then the primary care is another big focus of this. So we can get into this in some of the conversation, but I think the need to move more quickly and accelerate the movement towards value-based payment is very sorely needed. Delighted to hear Dr. Sutton talk about CMS interest in moving that along. So let me just leave it at that for now in terms of time. Thank you.
Thank you, Steve. Next, we have Dr. Jose Peña, the chairman of the board and chief medical director at Rio Grande Valley ACO Health Providers. Jose, welcome.
Hi, good morning, and thank you for the invitation. We are a small ACO located on South Texas. We started in 2012, taking down some risks from the very beginning. So in track 2 ACO, then enhanced track, and now ACO Reach on the last couple of years. We want to thanks and applaud CMS and CMMI for all the value-based model created on the last 13 years, actually. And we are a testament on South Texas that we are a lot better now versus our time that we were on fee-for-service, in the before 2011, actually. Next. So we are very focused around the patients, how to improve basic primary care. We have about 45% of patients with diabetes in our area. So we focus a lot on that, and we are quite outcomes oriented, trying to decrease admissions, readmissions, and visit to the emergency room. We have some clinics in San Antonio, and we have had some clinics, and we currently have some clinics in New Jersey. Currently, we have about 5,500 ACO REACH, and the rest is commercial. Basically, we are a standard ACO REACH on global option with PCP computation. Next. Just to highlight a few ideas, and we can expand later on the discussion. But I think some of the challenge on the population-based total cost of care model, as ACO and ACO REACH, as it was mentioned before, we have a lot of competition, quote unquote, with the MA plans because the Medicare, traditional Medicare have decreased. In our market, MA penetration is already around 65 to 70%, and that make harder for the primary cares to keep the minimum of 5,000 patients to run these programs. Also, the financial predictability, as we know, MA have more tools. When we are in capitation, so the MA plans is more predictable for the PCPs and less risky. But I think there is many patients that don't want to be still on MA plan, and the ACO REACH is a great opportunity to enhance care and provide a lot of service that we are not able to in traditional fee-for-service. The cost is high to run this program efficiently. We think that it's about $1.5 to $2 million usually for small ACOs to be able to hire it, if not enough IT management and personal infrastructure that usually we don't have on the regular PCP practice. Same lines about data access utilization. We depend a lot of the claims-based information from CMS that usually is 2 to 3 months later. So we have some lags on action, and that put us in a more difficult position to deliver a better quality of service and to have more data for predictive analytics that are fresh. Next, please. We think, and we can talk about that later, but we are having CMS can enhance the current financial environment in the ACO REACH model. One of the big one is that this count from the total cost of care budget that is have increased from 3.3%, 3.5%, and now 4% from the top. So that gives us already a significant amount of money. We have a $100 million budget, and 4% is taken. So when we get to our saving and we save 10%, it's already 40% of that is gone. And I can discuss that more in detail later. We think that the waivers can be improved and with less regulation, so we can have better use. The same thing with the financial guarantee, that is a big burden for us. It has increased to 4%. So in the previous example, we have to have $4 million as a financial guarantee. So many of us have to put, our personal asset and clinics as a collateral with the banks just to have the line of credit, and that's a big burden. And having, again, money from the doctors to be frozen on the bank just to have the financial guarantee and run the program. So that's a big burden. As I mentioned, CMS, I think, should be able to provide data that we can have that we can use more handily. So next. The increase the upfront funding, we are on capitation, but I think for new organization to have more front funding will make more likely the PCPs to participate in this kind of program. And there is other thing like the expand our ability to work together with the CBOs will be good. The V28 HCC model is making an extra impact on MAs and ACO REACH. And I mentioned already the discount that is taken out of the benchmark that is probably the single biggest financial burden for us. Next. Thank you.
Thank you, Jose. Our final panelist is Dr. Tim Layton, Associate Professor of Public Policy and Economics at the Frank Batten School of Leadership and Public Policy at the University of Virginia. Welcome, Tim.
Thanks. I'm excited to be here and chat with you all. I have to lead with a caveat that everything I know about these types of models I learned from my good friend and former colleague. You may have heard of him. His name is Michael McWilliams. And so you're going to hear some like parallels, which actually have gone through all of the panelists' discussions so far. If you can go to the next slide, that'd be great. So I'm an economist, so I'm going to take the economist role and take the 10,000-foot view here. And what I want to emphasize in these few minutes is that I think that we kind of have two goals that we want to accomplish. And I think that there's sometimes confusion that mixes these goals up rather than treating them separately. So the first goal is that we want lower spending, right? And the second goal is that we want to improve the allocation of a fixed amount of money. We want to get more bang for the buck from a fixed amount of money that we give to these provider groups in one form or another. I think that we need to recognize that we don't actually need these models to do one, to lower spending, right? We can lower spending without the models. We can just cut payments across the board. It's not that hard to lower spending. And because, it's quite easy to just lower spending without the models, I think the real purpose of the models is to, right? It is to improve the allocation of a fixed amount of money, the way that all three of the other panelists alluded to. And the reason we want to do this is because it's really hard to set every payment for every service in fee-for-service correctly, especially when there's complements and substitutes, when various services have high fixed costs or high variable costs, et cetera. And what these models do is they provide us with an opportunity to take a step back and let organizations experiment with different allocations until they find the ones that deliver the most value to consumers, right? To allow them to invest in prevention, which may be really hard under a fee-for-service model. And I think our key problem is that we're trying to do both 1 and 2 with a single instrument. And when we do that, we end up doing a poor job of both. You go to the next slide. So the one point I want to emphasize today is that I think that what has come out of this as the key problem is this drive to claw back the shared savings via payment rules. And Dr. Peña was alluding to this earlier, and Michael did as well, so did Steve. But the key point is that any savings that the ACOs have to share back to the government will decrease the incentive for the organization to participate. Okay, I think that's an uncontroversial statement that you're taking money from them. And so they're going to be less likely to participate. And I think this whole shared savings idea is partially driven by this kind of weird, misguided, and dare I say, actuarial, is that going to get me in trouble, idea that payments should equal costs, okay? And what this does, though, in practice, is it actually leads to payment policies that financially disadvantage the models, right, in order to capture the savings. Basically, we're making goal 2 less likely to be achieved by focusing payment policy primarily on goal 1. I think breaking the two goals apart leads to a different type of payment policy that Michael alluded to, where we want all models to kind of be on the same level playing field. We want all the models to be paid the same amount for the same person, We can choose that amount to be whatever we want it to be based on what we think the right level of spending is. And maybe we pick a level of spending under which some models survive and other models die. That's okay, right? That tells us that, some of these models work at the level of spending we're willing to pay and others don't, and that's fine. But all the models should get the same amount, and then we can let the market decide. You brought an economist here, so you were going to hear that line at least once. But ultimately, what we want the ACOs to be able to do is take the savings and use it on things that people want. We don't need to force this, right? Competition among the ACOs and competition with fee-for-service in MA, which is pretty strong, should do that if the ACO can take some of that money and get loads of people to want it, then it's delivering more value for that same amount of money, and we should be okay with them doing that. Now, we may need to improve active choice and competition policy to achieve this, but kind of as my kid's favorite Star Wars show, The Mandalorian, says, this is the way. So remember that, though, that the purpose of the ACOs is getting the allocation right, not the level. When we confuse those two, we're thinking purely like actuaries and not like the way like policymakers. Okay, last slide, and then I'll wrap up quickly. Okay, now the big question here is how do you actually do that? How do you provide a level playing field? We've been trying to do this with MA and TM for years, and we've failed miserably. But like ultimately, this is a hard classic causal inference problem. We don't know the counterfactual traditional Medicare spending for people in ACOs and in MA. So how do we set payments to be equal across these different segments? We try to solve this with risk adjustment systems. Those have had major issues in the past, but I think they get kind of a bad rap because I think that these issues are solvable. If there's a will to solve them, we can use survey-based risk adjustment. We can randomize defaults to people to figure out how much different types cost in different programs, or we can just use the systems we have right now, but fix them, right? And we know simple fixes that can help improve these systems. But I think at the end, like I do want to make the major caveat that all of this leveling the playing field, letting kind of the market decide, really only works well if demand follows value. So I think ultimately the main thing we should focus on, aside from leveling the playing field, is improving choice architecture, pushing for more active choice, and engaging in competition policy if we really want to achieve kind of a kind of optimal global outcome here. Thank you.
Wonderful. Thank you all for the great introductions. Now let's move to some questions. In the interest of ensuring balance across different perspectives and questions, we encourage panelists to keep each response to a few minutes. First, I'd like to ask the committee if there's any questions from the committee initially. Lauren?
Dr. Peña, I'm very intrigued by the social risk score that you spoke about. You didn't have an opportunity to talk more about that. Would love to hear what you're seeing and what your recommendations might be for that.
Yeah, I mean, we live again in South Texas. It's a high poverty area with a significant amount of dual eligible patients and illiterate people. They just make a lot more difficult, to take care of them. Some of our patients don't speak or read English, have difficult time, even Spanish, to read instructions on the medication, believe it or not. So HCP LAN, the Learning Action Network, has been working on this, like social risk score. As a matter of fact, the ACO REACH have a component giving some weight to the dual eligibles, and also they are using this University of Madison map. I call the poverty map in short. So there is, some incentive already on the ACO REACH of extra payment for the 10% of highest poverty, but we think that could be enhanced, right? And some elements probably should be added on the program also, not only on those two factors, but access, there is some Z codes on the billing system when you can kind of let CMS know patients that have a difficult access to transportation, to housing, food insecurity, and others, right? So if we get like extra payment and we can show that we can use it to, in those gaps, right, to provide transportation. We are doing so now, but in a very limited way. And we are like very afraid of what is the regulation. Can we do it? Can we not? Etc. So we are like working with a local food bank. So we give donation and they can able, to do more food. But we are like very afraid from CMS in whatever we do because of the regulation. And this is, and so many, again, burdens that we just don't know what we can do and we cannot. And sometimes we don't have the money to ask the attorneys for everything that we want to do, right? But again, the HCP line is working on some recommendation in a social risk score that should be a kind of a percentage of the whole V28 model and that kind of thing.
Very helpful. Thank you. It looks like a couple of you may have wanted to add comment. Please jump in if you did. Otherwise, I'll pass it to Walter.
Do any of the other panel members want to add any comments to that? Okay, Walter.
Thank you for a really rich and informative discussion this morning to all our panelists. We've heard a lot about how unlevel the playing field is between MA and MSSP and other CMS, CMMI value-based programs. And the number that I think is published in the literature that Michael referred to earlier was roughly around 22% higher payments to MA because of various coding strategies and that kind of thing. But the kind of insight that Dr. Peña provided to me today was that this unlevel playing field could be even worse than I had thought because of the CMS haircut in terms of clawing back shared savings, right? So if CMS takes back 4% and then the MA is already 22% ahead, in essence, is it fair to say that the unlevel playing field is 20% worse? It's like 26% rather than 22, 23%. Is that kind of the right thinking about this?
I'd be happy to field that initially. That sounds right to me. The fact that these ratchet effects in the benchmarking sort of claw back the savings as they're produced means that if ACOs, if providers are spending money in order to lower that level of spending, then they're not recovering the costs of lowering spending, and so they could be even worse off in total cost of care models than they would be in fee for service. Now, that would mean that no one would participate. A reason they participate is that the benchmarks are in part set based on average spending in a region. And so there's some built-in subsidies for providers that are in the program. It's sort of, they get rewarded for their historical levels of efficiency. And so maybe they're not as worse off as if they were trying to save and losing the money invested in trying to save. But I think that's basically correct. And on the MA side, it's hard because although the increases in payments to MA have been unintended and they've been appropriated by insurers through various rent-seeking behaviors, they have nevertheless translated into additional benefits to some extent. And so MA has been this sort of backdoor financing mechanism for the Medicare program to expand coverage in ways that society may implicitly want. Like, we may want better coverage than what bare bones traditional Medicare offers. And so that now, I think, as other panelists have described, in particular Tim's comments, puts us in this challenging position of sort of trying to figure out how to be fiscally responsible, how to improve risk adjustment, strengthen competition, et cetera, without losing benefits below what we want for seniors.
Can I make a second point here too? That something that occurred to me while preparing for this and while listening to the other panelists is that the playing field is not level in two ways. One is in terms of what we pay, but also in terms of what they can do with the money, right? So like the MA plans can use it to provide things people want and get them to join the MA plans. For the ACOs, as Dr. Peña was alluding to, one, they don't even know half the time what they can spend it on, it sounds like, which is bad. But there are a bunch of things that they know they can't spend it on that the MA plans know they can spend it on. And that also puts the ACOs at an important disadvantage and takes away from this kind of level playing field that we'd be looking for.
Does anybody else want to weigh in?
Oh, you went, okay, go ahead.
Hinesh, next question.
So to your point, there's so many different components that Medicare Advantage has, which allow it to be more competitive, at least to the consumer in the marketplace. What would be the next incremental change that can happen on the fee-for-service side, MSSP, ACO, REACH, et cetera, that could bring it somewhat closer to being a competitive product that patients would be attracted to? And because I guess some of the changes that are coming is around the plan benefit design as well, as that CMS is having a little bit more scrutiny around what sort of benefits are being offered so that they're not just bells and whistles to get patients in, but really improving patient outcomes are aligned to those sort of things. And so as we're thinking about that scrutiny coming on the Medicare Advantage side, but also maintaining the competitiveness of the fee-for-service side, I'm just curious to know what that incremental next action would be.
Who's going to jump in on this one? How about Tim?
Oh, I'll try. Yeah, this is more of like a policy making or regulatory question as to like what's the kind of easiest next step, which is not like my particular area of expertise. But I would think the easiest thing is the easiest things would be to be clearer and more permissive about what the ACOs can do with the savings that they produce. I don't, like I said, I'm not an expert in how the policymaking process works, so I don't know how easy that is. But I would do that and simultaneously, like to the extent possible, shift more of the savings to the ACOs. I mean, like was alluded to, like TM is already at a huge disadvantage to MA, and we are, in a way, like disadvantaging the ACOs within TM even more. And so I would work to shift some of those savings back to the ACOs. Those would be the two things that I would push.
Yeah, I agree with, oh, go ahead, Dr.
If I can add, like I mentioned before, I mean, a clear point is this 4% discount from the top. That's huge. One. Number two, again, to give more flexibility to the ACOs to share some, to make it more attractive for the patients, right? Similar to do the MAs. Some of the MA plans are doing, like a little credit card with $100, $7,500, $125 per month. That's huge. I mean, a lot of our patients, they would, will move for that $100 a month. Can we do that? I mean, in the fee-for-service on the traditional ACO, we cannot give one penny, right? So to allow us to compete and to be more attractive for the patient to stay, one of the things that if CMS allows that 4% that they are taking from the top, for us to develop a dental plan or a vision plan, that will be huge, right? So that will make us closer to provide more benefits, to our patients, similar to the MA. So there is a lot of, and again, to decrease the regulations, the burden of the the overseeing of every details. That sometimes there is some waivers, and I can talk about that later, that we initially apply and then we need to drop it because there is, you know, the scrutiny of every cent that, you know, a patient pay a copayment on the Part B waiver for copayments that we start. If we don't know if that patient in the front doesn't know if that patient is an ACO or not, and charge the patient being an ACO or do not charge the copayment in a patient that is fee-for-service non-ACO, that already, you know, is a red flag, and our compliance officer at some point say just stop because we are at risk of an audit and we can get closed, right? So that paralysis for this audit fear, you know, is something that CMS need to work at.
And I would just echo everything Dr. Peña and Tim just said, and just one concrete version of sort of sharing savings with beneficiaries might take the form of Part B or Part D premium reduction. So then the more efficient ACOs look more attractive to beneficiaries. That helps strengthens the incentives to save, helps apply more pressure on MA plans to do even better. That being said, ACOs, even if the models are better designed and ACOs can keep more savings and have more flexibility, they're still stuck with having to finance the additional benefits for beneficiaries with savings, whereas MA plans can finance them with savings and subsidies. And so as long as those subsidies are in place, we are basically, from a policy perspective, favoring the MA program. That may not be a bad thing if we think the MA program sort of basically for all of Medicare is a good policy choice and we can make it work as sort of a single dominant program for Medicare beneficiaries, then that may not be a bad thing. I think that the big policy question in my mind that I mentioned in my introductory comments is, do we know that? How do we figure that out? What is the role of traditional Medicare? Do we need to keep it around to supply some competitive pressure on MA to discipline the market in various ways that could be very hard to do through a regulatory structure? And if so, if we want to keep it around, then we have to think about evening the playing field in terms of the subsidies.
Dr. Shortell, any comments to add?
No, I would just support what we've been, what others have said. And I think just to introduce perhaps something we haven't talked about yet in terms of competitiveness in the payment models and so forth is to remind us that we're paying whatever the models for a lot of poor care in our country currently. It's almost become normalized that Americans, we talk about the beneficiaries accepting the kind of care they're currently getting. And yet there's various estimates of low value care, for example, that about 20% of Americans receive care that doesn't help them and in some cases harms them. And it's estimated it's costing us $100 billion a year. Some estimates $300 billion a year. But at least $100 billion a year. There's been research done on this. All the specialty societies have weighed in on this. And it's probably about 7 procedures, actually, that account for a lot of the low-value care. So whether it's MA or the shared savings model, CMS, et cetera, how do we begin to address that particular issue? And I'll give you just an example of where some progress might be made, but it's for people to think about. As you know, about 8 or 9 states now are setting spending targets to make care more affordable in our country. And in those states, some of them are developing targets, not just around the spending target of it, no more than 3% or 3.5% increase year over year, tied to median wages in the state or GDP in the state, but also building in targets for moving to value-based payment models like we're talking about. So one example is California, depending on the product line, Medicare, Medicaid, commercial, et cetera, have set targets that by 2032, the value-based payment should be percent of revenue or percent of enrollees, ranging from 65 to 90%. Now, one way in which these spending targets can be made, of course, is to look at eliminate the low value care. Providers, of course, understandably, our hospitals, are resisting a lot of this. They need to be paid for, wage increases and technologies, and no question about it. But there is some relatively low hanging fruit there. But the American public does not realize a lot of this, and low back pain imaging, the opioids, etc., routine lab tests that are done for pre-surgery that doesn't give any more information that's going to enable the physician to act on it. So I just want to introduce that maybe into the conversation, a little bit different than what the main focus is today, but it cuts across all the payment models.
Thank you. Jim?
Thank you. Thank you for your time today. I'm struck with a couple of ideas that are kind of floating around in my head that are a little bit hard to put together, so bear with me. Dr. Peña, I appreciate your comments. Being a fellow Texan and knowing something about rural healthcare, I wanted to start with this idea that the dealing with this idea of choice being Medicare Advantage and traditional Medicare are kind of in the field to be available for physicians to choose to be part of both an ACO, MSSP, or Medicare Advantage. And in my experience, both are very desirable for physicians for various reasons, and clearly that's true for your ACO as well. And I'm curious about this kind of competitive pressure, or maybe competitive management opportunity between the two, which we're talking about this kind of unequal playing field between the two. But what I've noticed is that a lot of the patients choose fee-for-service Medicare because of the freedom of choice within it, as opposed to Medicare Advantage, which restricts choice at times because of prior authorizations and some of the regulatory aspects, but is creating more financial predictability for you, which I find just really interesting, right? As far as how do doctors in the field advise patients in Medicare to, moving them from one to the other because of the features of it are beneficial for the patient, even though maybe sometimes it's restrictive in their choices. And I'm just curious if you would kind of comment on that as in your own experience, and then from the economist at the table, reflect on that that proposition of choice, the population having the choice, but making that decision, but the lack of transparency in the value proposition each are being provided. Like, is that clear for the patients that being in a Medicare Advantage program that a physician might prefer the patient to be in and might be really beneficial for the patient, but it's low value care. At the end of the day, that the historical trend of that particular plan is lower value than, let's say, a more traditional Medicare. So if you wouldn't mind kind of taking on that idea and kind of providing comments, I'd appreciate it.
Sure. No, thank you for the comments and question. It is like you said. I mean, we live on both worlds, not only our patient but ourselves. So we work with several MA plans here in South Texas. Some of them offer a better value than others because some of them have more social workers, community health workers. They engage with us. They take really seriously the quality metrics, and they give us feedback, for blood sugar control, blood pressure, immunizations, and all of that. So some of the MA plans are quite good here, right? There is some others that we don't know anything, and we get a very hard time to communicate with them when there is a, the need of social worker or DMEs or extra, right? So they are not the same on that regard. And that is regarding the benefit for the patients. Regarding benefits on payment for the infrastructure and for the physician, the same idea go. Some of the MAs provide very decent capitation payments that allow us to have, let's say, integrated behavioral health. Some of us chosen to have a therapist in-house because the, difficult to access like psychiatrists and psychologists and so on. We, between, the extra income that we get from some of the MA plans and the ACO, we have been able to get nurse practitioners that go to the patient house for those that are bed-bound, wheelchair-bound. So, and this is increasing access and, making easier for the patient. So if incentives are used on the right way, and if there are, enough to deliver better care, but also to have more staff and to increase the salary of our employees, I think that's the best of both worlds, right? For us, the competition has been also in the minimum of 5,000 lives. As the MA penetration increase, has been more difficult to us to keep those 5,000 lives. So that way, we struggle almost every year to survive on that regard. But there is the good and the bad on both in the MA side and the ACO, right? So we cannot survive and we live on both. But definitely the landscape on South Texas have changed due to the ACO and the 4 ACOs in the market and 2 big MA plan. You remember the Atul Gawande articles 2010, revisited on 2015. The difference is major, and we have on clinical practice, we don't get the same number like before, the amputations, stroke, acute demise on the emergency room, and so on, because we are just practicing better medicine, better primary care, better primary prevention, and the cost of care, have been stable or decreased on the last 10 years. On South Texas, that was one of the highest in the country. We were before #1 on amputations and below, like below knee amputation in the country per 100,000 patients, and that's not the case anymore. So I think that the value-based medicine, different colors, has been a great thing for many communities in the country, particularly ours.
To your question about are the patients making good decisions here? Do they have the information that they need to make decisions here? I think that's exactly the right question to ask, and I think it's a really, really critical one, because obviously if they're not, then letting the market decide does not work, right?
To give just one line on that, patients get bombarded from information from the MA plans. We are not allowed to make any PR whatsoever, period. So there is a huge discrepancy there, right? And they take decision based on the paperwork that they get from the MA plan. And some of that, sometimes is not necessarily the decision, but that's an area that we don't even compete. I mean, we had the voluntary alignment, but what we get is 4 defaults. Patients that might travel out the area minimum, everybody else is getting the MA plan, right? We don't have that room to tell the patients, leave the MA plan and come to the ACO, prohibited, period. We get killed if we do that.
Right, and so I think that, again, in terms of leveling the playing field, this is another place that we need to make sure that the playing field is level in terms of the information that the patients have about the options available to them, whether that involves, ACOs being allowed to advertise or just letting doctors talk to their patients about where they would be better off in the trade-offs, or it involves, empowering brokers who are very active in this space, at least getting people into MA plans, but they don't face the same rewards for getting somebody into, a TM and an ACO, right? And so there are a lot of places where this playing field is not particularly level. I think, in this day and age, though, like whenever when my in-laws and my parents ask me what to do, I say join MA for sure. The government's giving them 20% more than they're going to pay for you in this other program. You're going to get like a lot of, not all of it, but you're going to get a chunk of that, right? And so it just makes it really quite, I think, yes, consumers making good choices is critical to this market functioning. Right now, the discrepancy is so big that I think the consumers are generally seeing that, and we see that in MA penetration numbers going up, up, up. And so I'm not super worried that they're not making good choices. It's just that the whole market is structured in such a way such that it's not a fair game. And yes, those choices are following the value for them, but not necessarily the value for society. And that's the trouble that we're in.
Thank you. Larry?
I hope I'm not being repetitive here, and I don't even know if this is going to come out as a question, but I'm confused. I ask myself, this is a policy issue. What does CMS want? What do they want? Do they want traditional Medicare? Do they want Medicare Advantage? Because the decision is obvious. To a consumer, I can pay more for this and get less, or I can pay less for this and get more of what I think I might need, but I'm not educated enough to know what I'm being restricted on beyond that. And we haven't really educated the public as to what the true decisions they have to make for decision between TM and MA. It comes out in Medicare Part D as well. When I'm on Medicare, and when you go to choose a Part D plan, you're immediately pushed towards the plan that gives you the lowest monthly payment. It covers your current meds, but if you wind up going on chemotherapy halfway through the year, it might not cover that. But the public is not sophisticated enough to load into that program potential medicines that they might have to go on and use that to judge how to pick which plan to choose. So I think every system's designed to produce the outcome it produces. And I keep coming back to the thought in my mind that this is designed to push everybody into, this is Pontius Pilate washing hands of risk and pushing patients into risk borne by somebody else. I don't know if I asked a question or made a statement.
Well, I'll just say I love hearing Deming quoted. So that'll be my first comment, because I think that's absolutely right, and we're getting exactly what the system is designed to do. It may be helpful to sort of think about this, because I think to Tim's point and some of Dr. Peña's comments and Steve's, clearly for this to work, and by this I loosely mean Medicare Advantage, but also the notion of managed competition, there needs to be competition. So there needs to be choices. The choice is completely overwhelming. There are a variety of policy strategies to try to help beneficiaries sort through those options, help guide them to the high value options. And we should all be thinking about what can be done in that space, because it's sort of, they're two sides of the same coin, right? If people aren't making wise decisions in their own self-interest, then insurers aren't going to be rewarded for offering more stuff. And then you have fewer insurers, or they're not offering as much as they should. And so that's certainly one way that we can strengthen competition within MA, but it may also require other competition policies. It probably requires reform of the risk adjustment system, because now there's sort of, rather than just competing on generating efficiencies and converting them into extra benefits, there's sort of competition to code the best. And then the winner of that game outcompetes their rivals. So there's a variety of needs from a sort of regulatory and market design perspective to make the MA program work better and make competition work better for enrollees. So that's sort of one suite of thoughts and policy strategies. Because it isn't, so then the big question is, okay, what's the role of traditional Medicare? And then you get into not just competition within MA, but competition between the programs. And how much do you need traditional Medicare around, and how robust or strong or generous does it need to play a role of exerting competitive pressures on MA if we can't generate that competition within MA that we need for that program to succeed for all beneficiaries? And to me, that's sort of the crux of the question. Clearly, in its current state, it seems like we really need traditional Medicare around, and the playing field probably needs to be more evens to give people a place to vote with their feet if they're not liking what they see in MA for whatever reason. But we don't have that really right now, and the markets in MA are highly concentrated, and we haven't figured out risk adjustment reform, and we haven't figured out how to help beneficiaries choose better. So there's just a ton of work to be done.
So I would just like to add to that a little bit as well in terms of information that consumers, whether or not it be traditional or MA or in ACOs, how many of us here today in the room there, when you choose a health plan, have any information at all besides the benefit structure and what the plans are, the names of the plans, etc. What I would like to see is, okay, in terms of my needs, I may not be able to predict them, very, very well. Maybe I can. Do you have, for example, the provider network in Texas, Dr. Peña's group? Do you have available to you the diabetes patients? Where do they score on blood pressure in control or their sugar levels in control? Just a couple figures on that. And if I might need to be hospitalized, what are the hospitals that my plan uses in my area? And just give me a couple of figures. For example, 3,000 US hospitals now subscribe to Leapfrog. Publicly reported safety grades on a bunch of measures, in particular hospital-acquired infections. Just tell me whether the hospital's A, B, C, D, or F, they grade the hospitals. Is it a hospital that's A grade or not? Tells me something about, am I going to get a hospital infection if I do have to be hospitalized, or sepsis, etc. Just a few metrics like that. We don't have that in the United States. We don't have that. We have the benefits. Okay, it looks better in MA. I pay less. I get more of these benefits, but nothing approaching just some basic metrics of the quality of care that I might receive.
I'm going to say, take a bit of an optimistic tone here and just say that I think people do make a lot of mistakes, and there's not sufficient information out there, and it's a problem. I want to emphasize, though, that when people make an active choice, they tend to do okay. The number one problem here is that people don't make active choices, right? They choose a plan once and they stay with it basically forever. But when they make choices, they do okay. We could help them to do better. I think the main way to help them to do better would be to provide them with information about not a billion different things, but instead just people like me, what's their satisfaction, right? And that's about it. But the key to making this market work is more active choice, not necessarily more information. The key is more active choice. And that's not just so that I'm re-optimizing from year to year. It's so that the plans have to design themselves with everyone in mind instead of just the people who are turning 65 and entering this year, right? As economists, we think a lot about what determines how plans design themselves. Elasticities, right? So if I lower my price by $1, how many more people do I get? If I increase my network breadth by an additional hospital, how many more people do I get, right? And if only the 65-year-olds respond to changes in my plan design, then those elasticities are super low. And so I'm not going to respond in my plan design. But if many, many more people respond because we help people to make active choices, not tell them what to choose, but just help them to make a choice every year, then the insurer's elasticities go way up. And at that point, they'll respond in terms of premiums, they'll respond in terms of network breadth. But the key is we need more active choice, and we need to figure out how to get that.
Walter?
Just a quick follow-up on what Timothy just said about active choices. So it seems like one impediment to active choice is the selection of MA is often a one-way street because of how Medigap policies work, right? Once you choose MA, it's hard to go back to traditional Medicare. The question is there any policy considerations that you guys are aware of underway where that might be changing, where maybe to promote active choice, we might kind of reconsider our Medigap policies regarding risk adjustment. Number one. Number two, real quick question, circling around to what Michael said around Medicare Advantage being a backdoor financing option to increase coverage for beneficiaries. How much of the subsidies going to MA is actually returning back in terms of increased coverage? So two questions.
Two very good questions. So to take your second question first, and maybe Tim can help me because I don't have the literature top of mind, but the estimates range. There's a wide range of estimates. I kind of keep in my head something on the order of 50 cents on the dollar about. And so plans are clearly retaining much of the additional payments as surplus, as profits, but some does make it through, and there are definitely clear studies that show that out-of-pocket costs inclusive of premiums are way lower in MA than in traditional Medicare, and so that's just sort of a fact that's hard to explain if it weren't for, you know, a good chunk of the subsidies making it through. The other thing to note about those studies is that that sort of rate of pass-through is much higher in competitive markets. And so it's just sort of like really underscores how critical competition is to the performance of the MA program. But the markets aren't super competitive right now. Something like 90% of MA enrollees live in counties that exceed the new threshold of HHI for being highly concentrated. About, I think, 60% exceed the threshold under the old definition. I'm forgetting your first question now. It had to do with active choice, but maybe you could.
Just reconsideration of Medigap policies so that it's easier to make traditional Medicare an active choice if someone made a mistake selecting MA in the first place.
Right. I mean, that's certainly one friction, and the Medigap market has other inefficiencies. I mean, processing each claim twice is another inefficiency. The coverage is arguably too generous in some ways with zero cost sharing for basically all of care. And so there are a number of reasons why one might want to reform the Medigap market. That's hard to do without adjusting the traditional Medicare benefit. There are some states that have different regulations like community rating and guaranteed issue. The trade-off there is then the premiums rise. They become, it allows people to flow more freely between the program, but it makes sort of the traditional Medicare plus Medigap option less attractive for the lower cost beneficiaries. So I definitely think that is something that we need to be thinking about as well. However, I think a major source of the inertia that Tim was describing is just sort of human nature. We all do it. I mean, we all pass up opportunities to open high yield savings accounts for years on end, even if we're completely, on top of our game. And so it does seem like the government as an agent on behalf of the public will need to step in somehow and sort of remind beneficiaries in various ways that there may be better options out there. Does that mean like a publicly financed broker system or something? I think we should be thinking about how that could be accomplished.
Yeah, I'll make 2 points about this as well. So one is that, of those 50 cents that don't go to the patient in these studies, we don't know how much of the other 50 cents goes to the insurer versus the providers. So as Dr. Peña was alluding to, sometimes they get, pretty good capitation deals with, the MA plans. That's because they're actually passing through part of that additional 50 cents in that way. So there's not great work on understanding that. So some of it is there as well. I think to the Medigap thing, like this is tough because like the reason why, you know, people get risk rated when they go back is essentially because within the traditional Medicare structure, you want to incentivize people to join right at the beginning, because otherwise you get this adverse selection problem where people don't buy Medigap until they get sick. But I think there's some fairly straightforward fixes here, right? Like, you know, not fully risk rating people when they come from MA, but still fully risk rating them when they go from TM without Medigap to buying Medigap, like things like that, that would be pretty, you know, incremental changes that could help with this. But yeah, as Michael alluded to, I don't think this is the biggest reason for a lack of active choice. It's one reason, but I think the biggest reason people just aren't paying attention.
Jay?
Thank you. A great discussion this morning. I just a couple of questions before my head explodes. One would be the fact that no patient chooses an ACO. So, and they're not even aware when they're in an ACO. So that's a totally competitive disadvantage when you start looking at Medicare Advantage, traditional Medicare, or ACO. So I don't know how we solve that issue. But we talk a lot about plan competitiveness, but I'd really like your perspective on provider competitiveness and what's happening in the marketplace, because the plans don't operate in a vacuum. And when you have all the consolidation of integrated delivery systems that are now offering their own plans and their own ACOs, and they offer one hospital inpatient rate to their own plan and their own ACO, and they offer a different hospital inpatient rate to their competitors in the marketplace, it totally inflates and artificially affects the rate setting process for everyone. So how do we work that into this policy discussion of making these plans competitive and more attractive and ultimately benefiting the beneficiary, as opposed to increasing margins for integrated delivery systems, whether it's on the insurance side, the ACO side, or as a provider?
This one's for Steve, I think.
Yeah, well, let me start off at least. I think I alluded earlier around the vertical integration part of that. Of course, there's been a lot of horizontal consolidation over the years of all these integrated health systems. So, you know, the FTC, there's certain things they can do. They by and large have not so far, and we'll see what happens with the current administration and so on. I mentioned earlier the idea of contingent, you know, approval of some of these arrangements, contingent on, you know, the fact of that prices do not rise in the ensuing year, and various quality metrics, low value care, and so on are reduced. Another element here is the fact that in some states, about 9 or 10 now, we have these spending targets. Okay. So what I'm familiar with on the advisory committee here in California, but I've also looked at Washington, Oregon. Of course, Massachusetts has a lot of experience in this as well. And Michael, maybe Tim can speak to that. It has to do with the enforceability. In California, there's going to be real penalties on the providers in terms of if they do not hit the spending target. And it's not just performance improvement plans, but actually paying financial penalties and then setting certain targets for the following year. That is beginning to, you know, get them to think through some of what they're currently doing in the way of spending and how that spending can be changed. And we'll see whether or not what the impact of that is going to be. But that is one thing that's occurring in about 9 or 10 states to change provider behavior around, well, just to take the case here in California, Northern California, over the years, Sutter used to say, well, you got to take all our hospitals, you got to take all of them, same prices, right? You got to have all of them in the network. Well, that's no longer going to be the case in California. And so I think a combination of the FTC and actually sending these targets to create a pressure and incentives for the providers and the plans that the providers are in to change their behavior is what's going to be needed. Short of that, I think you're going to continue to see some of the consolidation, vertical integration. And, I think the big challenge is going to be for Dr. Peña and others, the smaller practices, how do you get them into value-based payment? And I think some of the things that CMS is doing should be, if anything, accelerated. So making primary care or making care primary is one initiative. Upfront investment funds for team development and technology, EHRs, and so forth, capability investments will be needed for some of the smaller practices going forward. The other thing I will say in terms of rural America and some of the problems there is what might be done to encourage urban-rural alliances and partnerships in the way of, they may not be consolidations as such, ownership models, but models where urban health systems make arrangements with rural health systems to provide the capabilities and resources needed. Telehealth is a part of that, of course, as well. So there's some things going on in New York State that you may want to take a look at where Cooperstown, I think it's the Baseball Hall of Fame, but Bassett Memorial Systems of Rural Hospital in Cooperstown is working out arrangements with some of the academic medical centers in New York in order to get some resources around value-based care in rural America. And there's a few other examples of that as well.
I'll just make a couple additional points. I think Steve is absolutely right. I think Steve was alluded to the commercial market in a lot of this, and that's really critical here. Like it's going to be very hard to preserve or improve competition in provider markets without some sort of essentially price regulation, whether that takes the form of regulating fee-for-service prices, the most extreme, maybe a cap, or regulating total cost of care targets in some way. While I'm very supportive of antitrust law enforcement efforts, and those are quite critical, it just does seem like the point we're at now, it seems hard to unwind a lot of what's been wound. And so on the commercial side, it does seem like the prices is really the key thing to focus on. But then getting back to sort of value-based payments or total cost of care models, I think there where we, at least in the public payers, where we're not as worried as much about high prices from market power, we do need to be mindful to design these models in a way that doesn't entrench the market power that's been amassed by providers under fee-for-service. And one way that they may unintentionally be doing that is that the models in a lot of the accompanying pay-for-performance programs has just created a level of complexity and cost of just participation that is just well beyond some of what the smaller organizations can afford. I mean, just you kind of have to like hire a bunch of consultants to deal with all of this. And so that burden, that complexity, if it can be simplified, then the models would have a better shot at supporting what Steve laid out at the outset, or said at the outset, which is that in principle, they should be pro-competitive by giving organizations of any type an ability to compete. So, a smaller primary care oriented organization may not be able to compete on fee-for-service. The revenue is just not going to be very high. But in a total cost of care model, they actually have stronger incentives to generate savings, and they may be able to compete on that basis, at least in a system like Medicare, where the prices are set. So it's sort of like there's different levers to be pulled in the different markets, but with respect to the total cost of care models, we do need to think about the complexity.
And Jay, I like what you described, about like this type of foreclosure scenario that you're describing, because I think it's something that's been largely overlooked. So there's different types of consolidation, there's horizontal, there's vertical, there's different types of vertical consolidation. And the one that I think is happening more and more and more, and that the FTC has a really hard time figuring out how to regulate, is consolidation between payers and providers. And when that happens, there are a lot of efficiencies that can occur, right? Because like if you have a payer provider that's consolidated, then they're automatically in a total cost of care model for everything they do, right? And we don't even need the government to do it. They're automatically in it. And so there's, and we think those are good. So there's efficiencies that can occur. But at the same time, what it does is it makes it so that that integrated entity now wants to prevent people from other integrated entities from coming to their providers, so that encourages the patients to join their integrated entity rather than the other. So the classic example of this is UPMC in Pennsylvania, where they had a health plan and they had University of Pittsburgh hospital system, and what happened was they said, okay, like, we're not going to accept Blue Cross anymore. And so Blue Cross bought up a bunch of hospitals and said, okay, these hospitals are not going to take UPMC anymore. And you get in this situation where if you want to be an insurer in Western Pennsylvania, you have to own a hospital, right? And at that point, the barriers to entry are much higher than ever before, right? And so the problem is that this is a new kind of integration that the competition authorities have not exactly figured out how to deal with yet, because of these trade-offs of efficiencies versus these types of foreclosure activities. And so I'm not optimistic that there's going to be a lot of action from them. And so as Michael was alluding to, I think our best move is probably to just decrease all other barriers to entry in this space, because we know there are going to be more and more coming from this foreclosure. And so there are other things we can control, like the complexity, the regulatory environment that makes it hard to enter these spaces. Shrink those as much as possible so that at least, on the margin, like, the different organizations have a better chance against these behemoths that keep being formed.
I'd like to thank all four of you for joining this meeting. This helped us cover a lot of ground during this session, and you're welcome to stay and listen to as much of the meeting as you can. At this time, we have a break until 10:55 a.m. Eastern Time. Please join us then, and as we welcome a great lineup of experts for our listening session, which will explore how to maximize the participation of beneficiaries in accountable care and improve the sustainability of effective population-based total cost of care models. Thank you.
Produced by the U.S. Department of Health and Human Services.